I'd like to welcome everybody tonight to the COVID-19 series. Tonight, Boston Medical Center is going to present Innovation in Informatics, and we are so happy and pleased to welcome Geralyn Saunders, the CNIO at Boston Medical Center, Lois Howry, the Ambulatory Clinical Lead, and Tami Chase, a Nursing Director in Pediatrics, Family Medicine, Quality Metrics. This program will be brought to you by NENIC, and we'd love to have you visit us online at our website, and also take a minute to visit our YouTube channel, where past presentations are available of many of our lectures. The speakers have no potential conflicts of interest, and there's no commercial support for this program. And on that note, I would like to welcome our first speaker.
Thank you for inviting us tonight to speak about how we've responded to the COVID-19 pandemic. I have a number of my informatics team on the line with me tonight, plus Lois is going to do some of the presentation along with Tami Chase, who's one of our ambulatory directors for nursing for pediatrics and family medicine. So I'll just get us moving. So this is
Geralyn, Geralyn, can you put in the full slides, just because we're recording it?
Sure.
Thanks.
So this is the picture that Mary was talking about. We did this a week and a half ago. And then we added Tami and Monty on the side there so that everybody's available. So here's the three of us, and Tami will start us off. Lois will follow. I'll follow Lois. And then Lois will come back in and talk a little bit about what we did with the Newton campus, and then I'll do the closure. So hopefully we'll keep it within an hour. So these were our objectives. It was really one objective with 3 or 4 areas that we're going to address. And it's really pediatric delivered alternative measures care models, telephone triage, nurse protocols that we improved. We'll talk a little bit about Inpatient Innovations and how we opened a COVID respite hospital in less than a week, i.e. 4 days. So this is the BMC slide. You know, we've been around for a bit. We were a merger. Our mission is exceptional care without exception. We care for a lot of the inner city population. And our application that we use for our EHR is Epic, from ambulatory to inpatient to revenue cycle now. And so I'm going to turn this over, the first part of it, to Tami to talk about some of the really cool things that they've done in pediatrics during this pandemic. So Tami?
Great. Can everyone hear me?
Yes.
Great.
Yeah.
Okay. So thank you so much for the opportunity to be here tonight with all of you and share our story about how Boston Medical Center's Department of Pediatrics is bringing primary care and vaccinations to the community during this COVID-19 pandemic. Next slide, Geralyn. So just a little bit of background about BMC's Pediatric Primary Care Department. We are a large pediatric primary care that serves 14,000 unique children, adolescents, and young adults. We have an average of about 35,000 visits per year, and 85 to 90% of our patients are on public health insurance, and a significant proportion of our families are non-English speaking families. Predominantly, we have the languages of their preferred language is Spanish, Haitian Creole, and Cape Verde. Next slide, please. This is just a map that actually shows really where a lot of our families, our patients and families are located and reside, mostly in the eastern part of the state, heavily around our Boston Medical Center site. But as you can see, we have sprinkles all over the state, and a lot on the South Shore as well as the North Shore as well. And this is just to give you a depiction of like where our families come from. Next slide, please. Just realized I wasn't on video. Okay, so as you know, in March of 2020, this just a month and a half ago, it feels like we've been at this for a long time, but it really was a giant tidal wave of an impact by the state stay-at-home order, and really for the state of Massachusetts to prepare for the surge of COVID-19 and all of the information coming at us very quickly. The whole hospital really was kind of responding. And so during that time, as you know, the governor announced a stay-at-home order. We saw a enormous reduction, as did everyone else across the state, but a reduction in our ambulatory visits across the hospital. Our elective surgeries were canceled. We furloughed 750 staff. A lot of those were on the ambulatory outpatient side. And we were starting to see a disproportionate number of Boston's adult COVID-19 burden at Boston Medical Center. In terms of pediatrics, we had to close our inpatient and PICU units so that we could make space to care for the surge of adult patients. And all of our pediatric patients that were requiring inpatient stay were transferred to other hospitals. Many of our pediatricians and many of our nurses were deployed to COVID inpatient teams and redeployed to really be able to manage new roles to help with the hospital to respond to this crisis. We also had a challenge on our hands where we had a lot of newborns that were born of COVID positive moms, whether they were diagnosed as positive before they went into delivery or while they were in the unit. And that posed a really big problem for our team because newborns have to have a visit within the first 48 hours after delivery. And we had these COVID positive mothers that were even mildly symptomatic or just diagnosed. And so we really had a lot of issues to deal with and did a whole outreach to a lot of areas, and they were just not providing the services and going into households with anyone that had been recently diagnosed as a positive for virus. Next slide, please. So impact on our pediatric primary care was significant. We had, again, a dramatic outpatient, our volume was dramatically decreased. We were seeing about less than 20% of our usual volume per day. We really focused our essential visits on those well visits, the newborns and the well visits that would come in that were the 2 years of age and under, which is where predominantly most of the vaccines, the routine recommended vaccine series happens. And we were starting to divert all of our symptomatic infants and children to the pediatric ED as we were no longer seeing same-day sick visits and urgent care patients due to, our staff we had constraints with PPE, and we were really just learning a lot about this virus and how, it was affecting and how we were going to manage it on the outpatient side. So that was very, very impactful. We were also seeing a real fear among our parents that were calling us, our patients and families and mothers and dads, and that were calling the clinic and really did not want to come in. So on top of our reduction to essential visits, we were also seeing a very high no-show rate as people were declining and really just not coming. We knew that we were going to start to see a real reduction in vaccine rates, and the national data had indicated that there was a reduction about 40 to 50% of vaccine rates for that first week of April. So we were starting to see what we were thinking we were going to be seeing. Next slide, please. So this is on May 8th. This is the CDC has the MMWR report on vaccines, and I pulled this snapshot from their slide. And the top part of this shows that, for those of you that don't know, the Vaccine for Children program. So that's a federally funded vaccine program, and Boston Medical Center, among many other providers across the country, are Vaccine for Children provider sites. And so the top slide indicates the date is across the top, and you can see right around between March 9th and March 16th that there was a real reduction in sites ordering vaccines. So our local state Department of Public Health Immunization Program was stating that, and we were actually seeing it across the country. the slide below, the graph below demonstrates and correlates to the same time range, where you see in dark blue the children, less than 2 years of age, and then in light blue, those are kids that are 2 years, over 2, where a lot of the booster shots happen. But you can see across the country that that also other sites were trying to prioritize the children under 2 years of age as well, but there was a real significant decrease across the board in vaccine rates. Next slide, please. So while we were trying to figure out how to see all of our patients, we very quickly were able to, thanks to our IT team that worked amazing, we launched telemedicine, as did, a lot of the state, a lot of our partners across the state. But as we were doing our telemedicine visits, we were really identifying gaps in care that we were unable to provide, and really were getting worried about our patients. We were not able to see our kids with chronic medical conditions. And we knew that there was a lot of comorbid conditions of our family members of the children that come to us. And so there was a real fear among all of our parents and family members that if they brought their children into the hospital or came into the hospital, they were risking exposure, and therefore could then spread to either have their children exposed and come down with coronavirus, as well as their family members. And that was really, we were really seeing reluctance to come into clinic and come near the hospital. Let's see, next slide, please. So, we were really worried. I have to say, I give, my division chief, Eileen Costello, she was really my partner in this. And we just continue to every single day think about, what are we doing well? What can we do differently? And how can we figure out how to engage families? And as all of this information was coming at us at the speed of light, as I know you were all getting, we were really, unsure about how this virus was going to act, and what could we really do to be able to provide safe care. There's a stay-at-home order, yet we're trying to get patients to come into clinic, and we felt that that was a conflicting message. But we knew that we needed to make sure that we were trying to get vaccines to children, because even the slightest reduction in those rates in the state, you can see an outbreak happen. Next slide, please. So, we brainstormed, did a lot of brainstorming. We met with philanthropy, and we just engaged a lot of stakeholders to try to launch something new. And we basically decided that we were bringing vaccines and care to patients. Next slide, please. So we did a lot of population health to figure out, how do we reach the patients? Who do we reach out to? How do we do this? And we reviewed our missed appointment list. We went through our immunization registry and tried to pull data from everywhere that we could in order to try to collate all that data and determine how we were going to see patients. We did some panel management, and basically what we did was we sorted by children that were overdue for vaccines or due for vaccines, and then we sorted them by zip code and started scheduling for based on zip code the following week. Next slide, please. I think it's important to note also that we also did social health and social determinant screeners while we were on the phone with our patients. And so we tried to identify if they were in need of food or diapers or formula, or what were their other needs as well. So basically we used mapping to schedule all of the home visits, again by zip code, and offered families. We made lots of phone calls to families, and we started in the immediate area. In our team on the right, you can see we're really lucky to have Brewster donate ambulances to us, and this is 3 of our team members and our driver, Diego, who became our driver for the entire time and really didn't know anything about pediatrics, but he now knows a whole lot about pediatrics, so it's been great. Next slide. Really quick, just again, population of neighborhoods. We'll skip this one. Just trying to be mindful of time. Next slide. Vaccine storage and handling was a big problem. How do we do this? So we really quickly in the beginning engaged the immunization program, and vetted a process through the CDC on how to pack, a pack of vaccines in order to make sure that the range of the temperatures within that cooler was within the range that is guided by the CDC, and really had to put this pack together and do a lot of like every 2-hour manual data, and then additionally had to download all of that data from the loggers and submit those on a daily basis to the state. Next slide. I will not go into this, but this shows you this innovative way of using water bottles and a cooler to be in bubble wrap to actually make sure that we were ensuring that the temperatures were within range. Next slide. So this is, without going through this, a lot of pre-visit planning took place to make sure that our team was equipped with all of the information that they needed and the supplies that they needed out in the field. We did a lot of work on scheduling, a lot of pre-visit planning the day before, and then also the day of, and to make sure that they had everything that they needed, out on the field, and really knew about the patients and the families, and were able to address any needs, and making sure that we knew exactly what vaccines were going to be delivered to those patients and administered to those patients, and we didn't miss anything. We had a lot of huddles, and everyone was on the same page kind of every step of the way. Next slide, please. So after about our first week where we were just scheduling patients, what we realized and heard from our providers is that they really, really enjoyed, all of our team really enjoyed getting to see patients again and being out there to provide care. And we thought that continuity was, if we could provide some sense of continuity for our patients and families to see their own doctors, that we would try to do that. And so the providers got involved and reviewed their panels and the daily huddles, and we basically just scheduled doctors out for sessions at a time, and they mostly saw their patients with the exception of those COVID positive mothers who had just had newborns. And so at that point, we would just see them for, whenever they were due to be seen. Next slide, please. This graph shows where we were in the beginning of March. And as you can see, all of our visits were in person. And then around March 16th, we flipped to televisits with essential visits, which started to, as I was stating, week by week decline in the number of inpatient in-person visits that were coming, along with telehealth visits. And right around April 13th, you can see on the graph where it says 17%. That was the start of the week where we actually made outreach in the mobile unit. And we did 2 days that week, which demonstrates the 17% of our in-person visits were ambulance visits. But after that, you could see that more than half of our visits were ambulance visits. So more than half of our in-person visits were the ones that we were out in the community delivering care, which is pretty impressive. Next slide, please. And so, of course, we knew we had other patients out in the community that we couldn't reach because they were not within our catchment area. And so we really felt that we needed to do something to be able to provide care and access for those patients. And so we commandeered one of the hazmat tents outside the emergency room of Boston Medical Center, and we set up templates and a scheduling process for the tent, and really turned the tent into an in-clinic, basically a pediatric clinic, an exam room. And there was quick parking, and we pulled all of our technology out there, including our interpreter services. And families were able to call us when they arrived and come right into the tent to be able to see the doctor and the nurses and have their exam done inside the tent. And they were really, really grateful. Next slide. This is how we turned a hazmat tent into a pediatric exam room. So I just wanted to show a great picture of how we just used child life to help turn this basic hazmat into something that felt pediatric friendly to our patients. Next slide. So, this new model of care took a lot of population health and a lot of IT support for scheduling and documentation and billing. And we did not do it all in the best order because we were really building this plane as we were flying it, or building this ambulance and mobile unit as we were driving it. But the IT team was amazing. We they were able to build us a template, and we decided that we needed to submit and bill for home visits, which was brand new for us in pediatrics, and only geriatrics at Boston Medical Center was doing home visits. So this was really new and a new platform, and we really didn't understand I didn't actually understand all the infrastructure behind the build, but I am so grateful for the IT team who was able to just really get us up and running and build out the ability for our nurses to then document in these home visits, which I, again, did not realize that, if the provider opened up a home visit template, and that we as nurses were not able to document that. So they literally worked at the speed of light to make that happen for us, so that we could accurately document and make sure that we were, putting in all of the information that was necessary. We used Doximity for our phone calls out to patients, and that helped to make sure that any incoming calls, that they could identify that it was Boston Medical Center calling. We used Epic's Haiku to make sure that we had access to the EHR while we were out in the field. And we are now starting to use laptops with hotspots built in. And we also had access for interpreter services out in the field. Next slide. So not to, get into all of this, it's all there, but we had enormous amounts of lessons learned. One lesson, we reduced no-show rates by to 2%. So we were literally the average is 20% of a no-show rate in a typical pediatric practice. And by going out to them, we were down to 1 to 2%, which is pretty amazing. We're keeping our kids vaccinated. We're delivering really good care. Our families are incredibly appreciative. And at a time where we were, ambulatory was basically decimated, our staff had a real morale booster doing this. We definitely learned that we should involve our IT partners in the very beginning to make sure that we had the build when we were at launch. And so that was a really great lesson. Next steps are a lot. We're still evaluating this and determining how we're going to continue some part of this model. And we have a proposal in for DPH, and we have an IRB submitted for the evaluation of the model, so that we can continue to figure out what part of this we can continue. Most likely will be newborn care at the very least. Next slide, please. Just an inside look at our families of what we noticed outside of just delivering vaccines and doing the exam. Enormous amounts of incredible, unbelievable connections to our families. We've identified postpartum depression. We've identified domestic violence. We have identified a lot of social isolation and displacement, depression, anxiety, children that had not seen the outside, and families had not stepped foot outside of their doors. Digital divide, lots of social needs, lots of mental health support that we were able to get them connected with very quickly. So that was pretty incredible. Amazing, amazing things and lessons learned and connections to our families. Next slide. And this is just a little bit about the different areas and some pictures about our teams and the various things. And in the beginning, probably about a week or two in, one of my nurses, Priscilla Stout, incredible. She was on the ambulance a lot in the beginning. She's pictured on the left there. She quoted, the care of our patients and families is not contained to the walls of our clinic, and our families need us. And that's what we did. We mobilized and we went out to deliver what we could in a time of crisis, of a public health crisis. So I know we're saving questions for last, but thank you very much for allowing me to present, and I will turn it over to Geralyn or Lois for the next presentation.
Yep. Hi, this is Lois Howry. I just wanted to talk to you about our nurse telephone triage rollout. It was a project, next slide please. It was a project that had been identified about a year ago. I had been at BMC about a year, and it was one of the first projects that I heard about, that there was no standardized documentation for telephone calls. Most notes were free text. It got routed to the providers with not a lot of assessment information, so the providers were redoing some of that assessment work on the calls. And it was difficult to report on the volume of calls in the reporting we had, because there were missing elements, missing documentation, and oftentimes the call got passed from one clinician to another, and you didn't know who really was responsible for that call at the end. Next slide, please. So starting in August of 2019, the nurse leaders in primary care, which included general internal medicine, all of our pediatric clinics and family medicine started really meeting with staff in staff meetings and talking about the importance of documentation in nurse triage. So we showed Carol Rutenberg's video series, and we also had the books, the Barton Schmidt for Pediatrics and the David Thompson book for adult protocols, and the nurses were familiar with those. And we really reviewed it and made the nurses more aware of the protocols and how to use that in the telephone. But the documentation was still very difficult, and we really decided to proceed with the telephone triage protocols. It was notable that we used the stripped down version of Epic's telephone module that was used by the call center. So this would become important later because we already had the Epic product. We didn't need full Epic support at Go Live, which was rather timely. Next slide, please. So our timeline started when we submitted our project plan in the summer of 2019. It was approved to start for the first 2 quarters of fiscal year 2020, and we kicked it off in the beginning of November. And then I'll focus my slides on the scope workflow pieces, the protocol validation pieces, the build, test, and the go live. It was notable that almost all of our projects were canceled at the beginning of March due to the influx of COVID that we were seeing, and only 3 were allowed to continue. Not only was this telephone triage project allowed to continue, but we were asked to go earlier than planned. Next slide, please. So we assembled a team of stakeholders that included IT, nursing, and operations. And like I said, because we already had portions of the telephone protocols, our leadership decided that we didn't need Epic on site, which was fortunate because of the travel bans that occurred when we were going live. But we did have our TS Epic technical support person providing a lot of support and guidance to us during our build prior to go live. Next slide, please. So in addition to the stakeholders, we formed a work group, and Marnie is the analyst for the ambulatory team who was assigned to this project, and she was just really instrumental not only in knowing the pediatric clinic, but also having implemented a similar triage protocol at her previous hospital. So we were really grateful for her expertise in leading us through this. Our nursing work group met for 1.5 to 2 hours every week, and then we reported back to the stakeholders on a bi-weekly basis every other week. We did have a report writer, Bob Bishad, help us with some of the dashboards, and we did have transition in our instructional designer for the ambulatory team during this time. Next slide, please. So in our scope and workflow, we really wanted to establish some sort of basis for what the scope and what we were looking for from our nurses in this. So we really wanted to provide a standardized approach to telephone triage and improve the consistency of the documentation. It also was a consensus tool that we would all use this and document in a consistent fashion. We were hoping to reduce telephone errors and legal liability, increasing the trust of the physicians in the nursing assessments and documentation of these encounters. We also wanted to improve efficiency, make sure that we documented the questions, both negative and positive findings. We also thought that it would simplify training and education and allow a little more documentation by exception as we went through. So we also focused on all of the pieces of the documentation so that we would have the reason for call, which led to keyword in the protocol search, and dispositions, and whether the patient actually agreed with that disposition or not. Next slide, please. So these are our goals. We wanted to standardize the documentation in documenting all of the critical components and standardizing the note. We also hope to reduce the number of low acuity ED visits. We know when patients call into the clinic and they don't get adequate education or reassurance, they often take themselves to the ED to be seen. And we really wanted to reduce this number because our ED is very frequently slammed, and we can deal with these patients outside with very thorough documentation of the information that we're giving so that the providers can follow up really easily. Our process standards include documenting absolutely every telephone encounter. We wanted to paint a picture to enhance communications, so not just saying that there was a plan of care, but really what was that and what was the information that was told. We really wanted the nurses to document in real time and then the protocols actually provided some of a script for us to read to the patients and just check the box that that was the advice that was given. Next slide, please. So access, so in the important protocol, we use, Epic uses the Schmidt for PD and the Thompson for adult, and you have to buy the licenses based on the number of concurrent users that will be using the triage protocols at any given time. So we limit the protocol use to primary care units, as I said, our pediatric and adolescent units, general internal medicine clinics, and family medicine. Our work group, including the super user nurses, began reviewing actual protocols and playing in our system, becoming familiar with the dispositions, and we also made the decision to decide to implement only office hour visits at this time, as the nurses were making calls during office hours. The call center handled the night calls. Next slide, please. So the process went that you would go down the navigator, doing some travel screening if they hadn't had any, documenting who you were calling, and preferably what number you reached them at. If there was a need for an interpreter, that was built right in to dial the interpreter from the navigator. Then you started with a reason for call. Once it was assessed that the reason for call was a symptom and not just a refill encounter, the nurse would click the triage call at the top of the screen. That added 2 more sections to the navigator, one for the protocol and one for callback. Security is needed to provide the nursing telephone triage subtemplate. So that was done very soon after training. Next slide, please. So once you get into the protocol, you do your assessment piece, and then you get into the triage piece. As soon as you get to the appropriate disposition for triage, in this case, the patient should be seen today, immediately care advice and disposition become required. And there's links right at the point when you say, yes, this is the level of care that this patient needs right now. And then you get into the care advice, which is, again, scripted bullets that you can offer to the patient, reassurance, advice, and if it's very, very urgent, there's often first aid information that is given to the patient, and then the disposition is what you've chosen in that section. See patient in office today, or you know, go to the ED now, whatever the case required. Shortcuts can be added for the ED expect call, but due to changes in our ED bedboard, we decided not to do that, and we stayed with the ED phone call and verbal report to the ED. But we did implement the quick scheduling link so that if the person was to be seen in the office today, we could go right to the quick schedule and make that appointment right within the encounter and jump back into the phone call without losing our place in the screen. Next slide, please. So initially, our training consisted of 2 hours. We repeated some of what we had done in the staff meetings over the past summer and fall. So it was reduced to an hour of didactic review to emphasize the importance of why we were doing this. And then the second hour we spent in the computer lab, focused in Epic. I would start with a demo, and then we would move on to the trainees having some hands-on time. When we were asked to move up our go live, literally 2 weeks before our scheduled training would start was when we got hit with the start of the peak of COVID. So we were asked to move up the training, and we were able to condense training into 1 hour in the computer lab. We supplemented that with quick start guides, which we gave by email and then distributed in class. And our super users and instructional designers really helped in class, providing and at the elbow support for when we went live. The super user nurses were really, really critical to our success. Next slide, please. So when we first went live, we moved up our go live date by a week. We did not have the Barton Schmidt or Thompson protocols for COVID, so that Marnie had to really design those, and we were editing those every week. For those units that did not have triage, because it was only in primary care, there were smart phrases created for them that included the entire protocol, so that anyone who received a phone call about COVID would have the questions, the assessment questions, and the advice to offer to the patient. Next slide, please. So like I said, the weekly revisions were needed. We were changing, the CDC was changing their recommendations every week, and BMC practices were expanding. We set up ILI clinics so that we would refer patients there for testing if they were symptomatic. The reduced number of in-clinic visits made some sections irrelevant, so nurses were reading through those more rapidly. And then we were really ramping up provider telemedicine, so there was a lot of follow-up when the nurses routed the telephone encounter to providers with this really buffed up documentation. The other challenge we had was that most of our nurses were working remotely, so they had to learn how to access the computer, the Epic remotely, and managers really needed some tools to follow productivity and find out what was happening with the nurses outside the clinic environment. Next slide, please. So part of what Marnie and our report writer Bob did for us was create a manager dashboard. And this is a very small print, but you can see quality metrics, which include the volumes and the time for the length of the phone call. We can also see the productivity, and we can see all kinds of other metrics for the type of calls, length of calls, types of calls might be refill encounters, triage calls, things like that. Each nurse also had their own individual dashboard to monitor their own calls. And these tools were really, really critical to making the managers feel that their staff was really being productive and using this new modality. Next slide, please. Our initial goals were really hard to measure. We saw a very marked reduction in our low acuity ED visits, and I don't think we can attribute it to nurse triage. I think patients were scared to death to come to the ED. So we can't take credit for that, but we will continue to look at that as things return to a maybe more normal thing. We also have reports that can help us figure out if patients were admitted after a low acuity call. So the reporting will become even more critical as we get back to clinics practice as we knew it. Lessons learned. There were a lot of lessons that we learned with this. One, it's really critical to include nurses as super users in the working group. They were really helpful in training in the class, and they could anticipate questions from their peers. They were really critical for at the elbow support because we were working in small groups and very separated geographically across the campus. So they were really, really helpful in their clinics. We were not always closing encounters, and this project really helped us to be aware that closing the encounter really increased the reliability of our operational reports, and it gave credit to that nurse for having closed that report so that we could learn who was responsible for the progress of those calls. We found that some nurses had been on medical or maternity leaves at the beginning, so Zoom training was found to be very, very effective for training in small groups. I would do a demo, they would share their screen and do a return demo and get some playtime on the system. Marnie had set up a call-in number when we first went live to provide support, and she was sort of sitting as our support center, and that number was very heavily utilized. So it was a really nice tool to have for people who may not even be in clinic to have a call-in number where somebody was waiting to answer their question right there on the fly. We found it was much easier to train new or reassigned staff who were new to triage. The protocol gave them confidence, assured them that they weren't forgetting to ask an important question, and it also increased the confidence of the doctors in the information that we were providing. So it was really a win-win. Next slide, please. And we're on to Geralyn.
Okay, so for the next couple of minutes, I'm just going to talk a little bit about the innovations that we did in the inpatient world. And so very similar to what other institutions are seeing across the city, we needed additional inpatient space. And so we started to surge into those non-traditional areas. So we increased our critical care capacity by 23 beds. We could have added 9 more. Our IMCU went up 28 beds, and our med-surg occupancy went up 72 beds. And then we also had a couple of combo areas, one of which is the PICU. So we surged into procedural areas in the peri-op and PACU areas. We also surged into ambulatory, into pediatrics, and as Tami stated earlier, pediatrics inpatient really moved off campus. And then we also look at the emergency room and radiology, but unfortunately we were not able and never needed to surge into that space. So we needed to look at some specialty needs. So the whole device integration, especially for critical care spaces and for IMCU spaces, and then really all the monitoring equipment that we needed. And then there were some specific workflows for lab draws that, depending upon whether or not the area was an ICU or was a floor, the staff either used a system called Clinic Collector. They were part of the phlebotomy draws. And then one of the kind of neat things that we did, and Nancy Giacomozzi's on the phone with us this afternoon, was really take a look at using telesitter cameras. So we surged into an area which was traditionally an IMCU space. And so that space, those rooms had doors. And so to be able to really see the patient in a closed room, we ended up moving half of our 24 telesitter cameras to that space. We also then spun up the monitor at the nurse's station and then also another additional monitor down the hallway. So staff on that area really felt confident that they were able to see their patients at any time using the equipment that we took from the telesitter program. And then what we really had to do was also take a look at capacity management. We did a lot of whether or not we had COVID floors or non-COVID floors, and floors would change over from one area to another. We really managed that through bed planning. We had a lot of banners that were created in the system. And then we also had 3 times a week a multidisciplinary surge meeting that was really driven by one of our projects managers, which had a checklist, involved all the ancillaries, and really became pretty tight by the time we started to move into our 3rd and 4th areas. But we needed to make sure we had the type of unit built out. We started to build out one area in multiple ways. So for instance, our PICU could have been either an IMC or med-surg space or a critical care space. And then we looked for all of that work to be driven by a bed control staff. So depending upon where we needed to surge next, we ended up deciding that, well, that unit's not going to be med-surg, we're going to go with IMCU. And then, as Lois will talk about a little bit later, we did open back up our Newton campus as a respite hospital. And I say less than a week, but we really did it in 4 days. So this is just an example of our COVID banners. I will tell you that the feedback we're now starting to get about our COVID banners is that they're too large, and now the staff aren't seeing any of the other banners. So one of our lessons. And so during this whole time, we also did a fair amount of work with our training team. So the informatics team worked and partnered with the principal trainers, along with some of the clinical staff, including our educators. And we revised lesson plans. We improved our test out options for those experienced EPIC new hires. And then you can see we trained over 400 people in 3 weeks. Probably about 20–25% of them were trained remotely. The rest were done in the classroom. Created an awful lot of tip sheets. And then the informatics team really provided a lot of updates to security, really made sure that when staff moved from one area to another, they had the right tools. And this was really all driven because staff were being reassigned. So our PACU nurses were now moving into med-surg, or our endoscopy areas were taking care of IMCU patients. So it was really critical to make sure that we gave the staff the tools that they needed in order to function. And then the informatics staff really were a resource for not only the clinical staff, but the leaders on the floor for workflow and functionality questions. And then some of the other stuff that we did was we started to deploy some iPads. I know a lot of folks have done that to impact communication between the caregivers and also between patients and their families. And we tried to look at it as limiting the amount of time a staff member had to go into the room, use PPE, and also put themselves at risk. And we found it really helped a lot with patient and family communications. We have now started to deploy surfaces with a Zoom controller on it. And what you can do with those machines is that you're able to start the video outside the room and not have to be inside the room to actually start to monitor the patient. So that was really kind of a neat project. And with Zoom and the surfaces, we were able to use multiple devices. So we didn't also have to deploy an additional surface. We could pull it off the wows or the iPads or the phones. And then really for next steps, we're going to move into Rover. It's one of those projects that I've been trying to get at BMC for over 5 years now. Nothing like a nice pandemic to let you do Rover. So we expect to go live in early June. So we're doing Rover in about a 4-week rollout. Like I said, it's been a long-term request. And then we also started to look at Epic Monitor and whether or not that could really hit and meet some of our critical care needs, because we are going to stay in that IMCU space through the summer and flip back and forth between IMCU level of care and intermediate level care. And then we'll look at Epic Monitor as whether or not we can replace our third-party system that we currently have for telesitters. So our lessons learned is really, there was a lot of uncertainties. We would build a unit as a med-surg floor, and then clinical or operational leadership would say, nope, we need that as an ICU. So the teams ended up rebuilding the whole entire floor again. Took a lot with monitoring. I know our clinical engineering staff started or configured one whole area for device integration. Didn't need to do that. We needed to take that down and then move it to another area. So we got good at this. So by the 3rd and 4th unit, we were building each unit out in 3 different levels of care. We also had to change some of the things that we were doing. We had one vendor for our computers on wheels that had been with us for a long time, but that equipment takes upward of 3 months to actually turn around once we get an order placed. And so we couldn't do that. So we ended up going with a new vendor. And then during this whole time, we then needed to switch from Windows 7 to Windows 10 because we no longer could get equipment on the Windows 7 version. And then some of the things we also learned was, now that we are in an integrated system, sometimes some of the things that we do in one module will really impact another. And one of them was highlighted by case management, who at the very beginning of this year actually transitioned into Epic. They had their own system for forever. They became part of the Epic family at the end of January, but they started to use some of the functionality to enter in estimated discharges, which then ended up playing havoc to our bed management system. And now we're just going to turn it over to Lois so she can talk a little bit about how we opened up the Newton campus.
Yep. So we consolidated our campus about 1.5 years ago. So the East Newton building had been empty and was owned by the state. So it was completely unoccupied. When we got into the sort of 3 weeks into the pandemic in Boston, we realized that our homeless patients had really nowhere to go. If they went back to a shelter, they would, contaminate everybody there. So due to this level of need, we developed a partnership between BMC, the Boston Healthcare for the Homeless, and the City of Boston, and all the homeless shelters, Pine Street, that were in our geographic area. And we found that in the census in 2019, over 2,000 adults were living on the streets or in emergency shelters, and these close quarters really provided high risk for spread of the disease in a rapid fashion. So we got the keys to the building at the end of March, and many teams worked to make this happen with furnishing and getting the staff in. And the IT team spent 3 days building out 8 COVID recovery units on the 6th, 7th, and 8th floor. We decided not to use the former CCU space due to the lack of bathrooms. There were shared bathrooms because it was a critical care unit in its past incarnation. So 3 20-bed units were ready on the 7th floor by the time we opened on May 9th. It was really incredible that IT was able to build out these units for us in 4 days. And that really speaks to the experience that we had in consolidating our campus. When we moved out of East Newton and into the main Menino campus, we designed many, many units, expanded units, built beds, and it was really that experience that allowed us to do this so quickly. So we were ready for a total capacity of 200 patients should that be needed. And the patient status was determined to be bedded outpatient. All of the EHR tools were chosen to be inpatient workflows, but we limited our documentation, as you'll see in a minute. We received so many donations, it would be hard to give thanks to everybody, but Stop and Shop provided prepared meals. We got furniture. furniture. We got clothing so patients could leave all of the clothing that they came in with. They even had, you know, new shoes and underwear and full garments that they could shop for and wear. And it was really an incredible effort to put all this together. Next slide, please. We had to do a lot of training on the fly since this hit us so quickly. So as staff was being hired for East Newton, we developed full PowerPoint presentations with shot by shot of the screens that they would encounter in their workflow. The workflow was very stripped down. We did not use the MAR. Documentation of medications would be on paper, but we did design a lot of tip sheets for all the different aspects of admitting, writing notes, and posting vital signs, and they were all on our Internet Hub site. So we call it the Hub, our intranet for BMC. The EPIC trainers were on call for one-on-one instruction so that anyone could call, especially like an hour or so before their scheduled shift, and get some personalization and a run through of the documentation workflows. Zoom personalization sessions were very welcomed and were provided for all the providers that came from outside BMC who were not already providers within our system. Many nursing staff have been cross-trained to the inpatient roles from perioperative services, ambulatory, and several other areas. We also hired and trained a small group of new nurse graduates and put them into practice in East Newton prior to their joining our new graduate nursing program this coming June. The security team was really amazing and provided all the appropriate templates and access in the EHR in record time. As we were doing training, they were literally turning the access on for these people. Next slide, please. By 6:30 on Thursday, April 9th, we had 15 residents admitted. Our census grew to a maximum of 66 patients on 5 units, 3 on the 7th floor, 2 on the 6th floor. I had corrected this. It's 288 patients have been discharged with letters of completion. And they had to meet the CDC guidelines defining recovery from COVID. And some shelters did require negative swabs, which we were able to do at East Newton. Our units were separated by gender and all rooms were double occupancy. Greater than 60% of the patients came from BMC or from the ED. The rest came from shelters, other hospitals, from the arena, or had no designated home to go to and came to us. Some patients also lived with an elderly parent or another immunocompromised family members and didn't feel like they could go home, and they came to us for their isolation and recovery. Next slide, please. This was the setup of most rooms with donated furniture and a nice view. Next slide, please. The care team included a wide variety of providers. We had one provider in the facility at any given time. Nursing assistants were often retrained medical assistants from the clinics. We had nurses, behavioral health professionals, addiction specialists, social work, case management, and a hired outside security team. And they were all easily identified by their full protective personal equipment that they were wearing because everybody was on isolation. The patients did not have to wear masks. The staff would be fully gowned and geared up. This was the shortened respite navigator that we implemented. We limited notes, documentation to notes, and there were basically several note types. The providers would write an admission note. The nurse could write an admission note documenting medications the patient came in with. Those medications would be kept at the patient's bedside in a lockbox. Any controlled substances were put in the med room on the 7th floor in the locked medicine cabinet, and we did a paper count on the patient's admission and with every administration. The nursing notes defaulted a service of nursing, and we adopted smart phrases for COVID recovery unit, affectionately known as the crew admission, shift note, and discharge. And then there was an event template that anyone could use in case of a fall, a fight breakout, or a patient leaving AMA. And then anybody could document vital signs in a very pared down flow sheet. We added, about 3 weeks in, we added a watch precaution. Some patients seem to be a little sicker than others. So at the bottom, you could say, yes, this patient needs to be watched more closely. And we added that to patients' lists to indicate to that one provider who was on staff who might need a little special attention during their shift. Next slide. Discharge criteria. were determined by the multidisciplinary team. Basically, they had to be 72 hours with a fever under 99.9 without using Tylenol or ibuprofen, and they had to be 72 hours symptom-free, defined as that lessened fever, no cough, no aches, pains, loss of smell or taste, diarrhea, headache, other symptoms. Some shelters did require that negative swab, which we did do. So in summary, we opened on April 9th. Total number of patients seen is 288 as of the 15th. Our average length of stay was about 6 to 7 days. And the census also on the 15th was 51. Like I said, our max was 66, and we did spread out, and then we reconsolidated down to the 7th floor. Next slide.
So this is mine. Just to end the evening. So for our overall response, our next steps, we're looking in ambulatory to expand our outreach programs. I think Tami talked about not only did Pediatrics start the outreach during the pandemic, but we also had a Geriatrics at Home patient program. We look to increase telephone and video visits, enhance nurse triage. For the inpatients, we are decanting and hopefully returning our areas to their previous specialties and returning our pediatric patients to BMC. We will continue to monitor the challenges that we have in critical care. We are using the flexibility now in the system for bed control to really assign the level of care. And then during this whole time, we also retooled inpatient nursing documentation and implemented disaster documentation, and we are in fact rolling out Rover. So in summary, challenging times allows you to really be creative. I think it really highlighted the need to have an informatics team. My group really did an amazing job. We could be very, very productive. Of course, there were some things that we, during our downtime, we actually revised downtime policies. And collaboration was really the key with both management and education. And then we used our network, whether it was NENIC or some of the other nurse informaticists that we know, but we really truly appreciate the sharing of information that we got. We really used partners' disaster documentation, templates, tip sheets, some of their build to help us turn over our documentation in less than a week. And then also we've spoken to Leahy, and we're looking at how to install Rover during a fast install. So it's just a great opportunity to be able to share with your colleagues across the city. So I think we finished in an hour. I'm pretty surprised that we were. Wanted to thank everybody. I want to thank Tami and Lois for presenting with me this afternoon, and really just to acknowledge the fact that I also have some other teammates on the phone with us, and this is really the group that is available in our contact information. So Mary, I'll turn it back to you.
Well, I just want to take a minute and really thank Boston Medical Center for sharing all this information. It was really a dynamic presentation. Lois and I had talked earlier, and she rattled off all these ideas, and she asked me which one, and I said, all of them. I think maybe a little bit to her dismay, but I know this is a time for really looking at how we can push information out that really reflects the skill set of your dynamic informatics team and your leadership. And I really want to thank you for putting this just wonderful presentation together. And with that, I'd like to open it up to questions and let people ask questions that they may have had over the last hour. And remember, you have to unmute yourself.
Geralyn, this is Palowalski from Brigham and Women's Faulkner. I do have a question about how you can try to position yourself to be able to maintain these programs moving forward, knowing that the financial implications of this disaster may be significant for all institutions.
So what we really found was, because we were really focused truly just on COVID work, we could get things done very quickly. So whether it was expanding the telesitter program, whether it was changing our documentation, whether it was starting telephone triage. We really implemented them quickly, and they knew that there was a benefit for actually to do that. The ICU workings with Telefit was a safety need. The staff in that area and the ACNO in that area felt like they really couldn't adequately care for an ICU patient in a room that had a door. So that really kind of helped us drive that. We knew we needed a mobile solution for nurses for med administration. They were starting to do some very creative, not so great workarounds to do barcoding of bracelets and medications and essentially do that work outside of the room and then go to the bedside. And we know with a Rover solution, we can actually do that easier and better and safer. So I know it will be challenging from a financial point. We have an opportunity though now to take advantage of this need. And I think it's really up to us to really jump into it. And I don't know if any of my team want to make any other comments.
Thank you. I hope you're showing us
Sure.
the way to move forward, because being a part of a partners organization, you know, all of the things that you've talked about, many of us have implemented, but it's the long-term support and keeping it financed that may be the biggest challenge for us.
I always said to people, the best thing and the worst thing about BMC is you get to do everything. So we really got to really move things along pretty quickly and take advantage of this opportunity. We really had a very supportive leadership. IT is very well positioned within the institution, and we really were able to deliver on a number of the initiatives that they needed to do.
This is Laura McLean from the Brigham.
Hi,
Hello. Really great work. Really, yeah, you should be very proud, especially with that vaccine program. I'm curious about the triage, the nurse triage. Did you only go with the COVID triage, or did you take advantage of all of the protocols that are available?
I'll take that, Laura. We decided to go live with all of the protocols, but it was sort of easy for some of the nurses who are a little more challenged in the training to use the COVID protocols to get most familiar with. So that was the focus, but most nurses embraced all of the protocols and took all the phone calls, sometimes combining protocols in one phone call. So yes, we did use, I think there's 240 adult protocols, 245 pediatric protocols that were available to us, and we used them all.
Excellent.
So thank you.
Okay. Yeah, we'll be calling you.
Do you want me to just add in, Lois, about a little bit about the protocol? So what was really incredible is that, you know, with all of the information changing so quickly around coronavirus, COVID infection, and we were getting information from Barton Schmidt and Thompson, but that was different for Massachusetts. So what was being pushed out was not what we were seeing in our immediate area around community spread. And so we were able to really daily, if not every couple of days to every day, getting and gathering new data and uploading those specific protocols and adjusting them to meet our current state of what we were seeing, and also what our BMC internal processes were around referrals to either the ILI or the ED, or, you know, so we were able to utilize that to really support the nurses with all of the work that was done on the phone, because everything was shifted to the phone. So that all of our nurses, there's, you know, all of that foot traffic was then shifted to needing to support all those patients on the phone. And they were all calling, hundreds and hundreds and hundreds of calls.
This is Marnie. So I'm on the IT team for the nurse triage part, and I'm not sure if they made it clear, but when we first, because of not having the Thompson and Schmidt protocols like right away, and them not really being, meeting our needs, we actually customized the COVID nurse triage protocols for the first, 3 weeks, month? Then when Thompson, and I don't know if you guys, I don't know if anyone used them or knew about that, but Thompson Schmidt had made them free for everybody. So like, use the COVID protocols anywhere, but like we were just running it differently. So they didn't work for us. So it wasn't until, about a month in that we actually switched over and started using the Thompson Schmidt protocols with some customization still yet, but we started off with custom protocols the first month. So we were
protocols for the COVID-19 or custom, you actually customized some of your other protocols too?
No, just the COVID-19.
Okay.
Yep.
Okay. And so right now you're just using out of the box Smith and Thompson, is that correct?
Correct.
Okay.
And I know somebody asked me about finances, but I will tell folks, we also got a lot of donations. So all our Surfaces, all our iPads were donated. We did get to use services for 1, 2, and 3 months free of charge for different pieces. We got a fair amount of phones that were donated. So we did get and I think Tami talked a little bit about even the van or the ambulance was donated by Brewster.
Yes, that's correct.
A lot of folks were extremely generous during this time and have been.
I have a quick question. I noticed that you had a dashboard that looked at productivity during your transition to telehealth. How was that managed, and were there lessons learned about what metrics people were actually looking at to assure productivity of people who are off-site? Because I assume this is a new skill.
You want me to take that, Lois?
Sure.
Yeah, so that's a really great question. But yes, we transitioned for the first time. We transitioned nurses to several of our nurses were at home doing telephone triage because of various reasons. And we were able to look at, I specifically was able to look at those folks that were actually at home and be able to determine what their average calls were for an 8-hour day. And I then compared it to the other members of the team that were on site. It was the first time I was able to start utilizing the reports in that way. But this was, before this dashboard, we've had nothing to be able to put a number to information around total number of calls that nurses were taken, total number of like how long each call was taken, the nurses. Of course, the COVID calls were taking nurses a lot longer because they required a lot of reassurance and education. But the dashboard now provides us with a lot of opportunity. I can calculate how many calls are on a given day to determine how to allocate staffing. And this could also help us to be able to put an FTE proposal forward with what is our real number of calls, what has it increased and changed during COVID, and what will it change like while we're pacing ourselves through the rest of this pandemic. But it's been really good to be able to look at exactly that for the first time, like can we monitor productivity? And it has helped me to make a decision of whether to keep a couple of my nurses at home for the next couple of months to do telephone triage, because I can monitor it and make sure that they're being productive.
Thank you. I have a question too for Geralyn. Is there any discussion? I mean, I know you're talking about finances, et cetera, but what is the conversation? I'm just curious, what's the conversation? Do you anticipate a surge? So I know you said you're looking to transition units back. Like, how are you planning for the unknown?
So in the critical care space, one of our IMCU areas will toggle between both critical care and IMCU. So that space will stay there. So we'll have surge capacity of about additional 15 ICU beds. We think we're going to need that through almost the summer. We also have surge capacity now in med surge areas. We currently have the pediatric area taking COVID adult patients. We could double those rooms, so we're looking at whether or not we would move PD to a different space when they returned on campus. So we do know that we need pediatric surge areas. So, you know, it is part of our plans. So we just can't decant. We're doing that methodically. So we've moved out of probably the scarier places first that really were outpatient or ambulatory areas. And then we started to move out of the procedural and the OR spaces so that we could start up some of our surgical processes or surgical procedures starting next week. But we will need to keep surge space open or available.
Thank you.
And I don't know if I'll ever get the ACNO to give up all of the telesitter cameras for critical care, but we're working on that.
We did discharge our 1,000th COVID patient from BMC this week.
So I'd like to take one or two more questions. Anybody have another question?
This is Artie. I have a question. Last month when Christine presented, they talked about documentation reduction, basically, and reducing the burden of documentation for nurses during the pandemic and spending more time taking care of the patients. And then during the Q&A, we had a little discussion about, well, some of the things that they've implemented, in other words, they've taken away some of the required documentation. You know, the question is, do we really need to put it back? I would ask the same question of your efforts. And it's amazing what you've been able to do in such a short amount of time. But can you foresee maintaining any of the efforts that you've initiated and or not putting back some of the things you've replaced?
Meg, do you want to take that? I don't know if she's on mute or. So I will tell you that our staff is really pushing us to relook at all the required documentation. And our nursing leadership is also. We are just kicking off the discussion on Thursday with our educator, our informatics group, along with some key other individuals to take a look at truly what it is that we were requiring and how and what we need to add back. Going back to the status quo will not be accepted by our staff. It will be very challenging for them to leave what they actually currently have. So it will really be a major push of ours for the next couple of months to really retool our inpatient nursing documentation tools and streamline them. Epic has some toolkits available. There's been a fair amount of work done out of one of the hospitals out of the University of Colorado and the project is called Project Joy, and it's really looking at, I think it was their admission assessment and really where did the requirements come from different areas. So we're going to relook at those tools along with some new revisions we've gotten from CMS. I did reach out to partners just last night because I rewatched their presentation to see what they were doing also. So it's kind of nice to have somebody else in the city that you can actually ask questions to. So we're not going to go back to the status quo. We will be challenged by not only our clinical staff, but also our nursing leadership. I don't have a definitive plan right now, but we will have one in a couple of weeks.
Geralyn, we had Dorinda Sutton. She's from Cerner, and she presented about a year ago. But she talked about some of the things they had done, obviously pre-COVID, but how they had looked at working with about 10 organizations, but don't quote me on that, but a number of different organizations where they're looking to reduce documentation. And she had a really nice methodology. It's up on the YouTube channel, and if I can send it to you.
Okay, great, thanks.
Yeah.
You know, we're fortunate that we also have a Nursing Informatics Council. We're into our 5th year. We have over 35 nurses that meet with us on a monthly basis. Pre-COVID, we met for a day, a month in a training room. We know we're not going to be able to do that going forward, so we're looking to doing Zoom sessions from maybe 2 to 4 hours. We're going to hopefully kick them back up in June, but we're going to use that, that talent within our clinical staff to help guide those discussions and those decisions on what do we need to do for nursing documentation going forward.
One more question. Well, it's not a shy group, so I won't be surprised if you get some questions that come to you via email, maybe offline. But I'd like to really take this minute and thank everybody from Boston Medical Center. It was really it was a fantastic presentation and really reflects the standards and excellence that you bring to your patient care, and how that has really benefited everybody that has had a chance, that has, you know, has gone through this, I shouldn't say chance, but everybody that's experienced COVID or just trying to receive healthcare in these very difficult times. So thank you again. And that concludes this presentation. I do want to let people know that on June 23rd, we're going to have another program from 6 to 7:30, since this seems to be well received. Lee Williams from Boston Children's Hospital is going to be speaking, as well as Kathy Turner from Meditech will be speaking, and I think it's going to be another really excellent program. And please make recommendations of things you're interested in when you do your evaluation, and I hope to get that out to you probably not tonight, but probably first thing in the morning. And again, thank you very much to all of our speakers and to the Boston Medical Center's Informatics team. That concludes tonight's presentation.